I think Assalamu alaikum and good evening to everybody. This is a galaxy of people. I've seen third time of Kashmir Academy of Private Physicians, and all goes to Dr. Sarosh Khan, who is the mentor behind all that. And the chairing session, there are galaxy of very important people. Professor Durrani, a highly respected person who has done so much for this society. Professor Umar Javed Shah, my friend Dr. Wahid, and Professor Sadru. Now, at the outset, I must thank Dr. Sarosh Ahmed Khan, Senior Consultant and Director at Naseem Medical Center, Srinagar, for the kind invitation and for asking me to give this talk, which is on alveolar echinococcosis in Kashmir, India, an emerging endemic zone for echinococcus multilocularis. It's a major problem, health problem, as I will put. We have been working on this disease for now over 5 years, and I will start with the lecture. Kashmir is emerging as an endemic zone for alveolar echinococcosis and poses a public health threat. Alveolar echinococcosis. Kashmir is emerging as an endemic zone for alveolar echinococcosis and poses a public health threat. Alveolar echinococcosis is caused by larval stage of the fox staphyworm Echinococcus multilocularis. The disease primarily affects the liver and causes bulky tumors which infiltrate centrally to the vascular and biliary system and periphery to the liver capsule and adjacent organs. The tumors metastasize to lungs, brain, and bones. The disease, left untreated, is uniformly fatal within 8 years. Echinococcus multilocularis is distributed across the northern hemisphere. It includes northern Japan, northern Russia, northwest China, Central Asia, Central and Northern Europe, North Central United States, Northwestern Alaska, and Northwest Canada. Alveolar echinococcus is an evolving threat to public health. Around 18,235 new cases per year are recorded every year in the world, with a disease burden of 660,000 disability-adjusted years. China accounts for 91% of such cases, and the disease is highly endemic in 7 counties of northwest China, wherein disease prevalence is over 3% in general population. Recently, there have been a significant upward trends in the occurrence of human infection in Europe. The eggs of Echinococcus multilocularis need optimal environmental conditions, including high humidity on a superficial ground layer and dense vegetation, to maintain longevity and promote transmission. Because of this, the infection is restricted to the northern hemisphere alone. Adult worms of Echinococcus multilocularis live in the intestinal tract of canids, including red fox, Arctic fox, and coyotes. The adult worm is 3 to 5 millimeter in size and has a scolex, a short neck, and 3 proglottids. The gravid proglottid contains an average of 823 eggs passed in the feces. Orvicolini, a subfamily of rodents including voles, lemmings, and muskrats, serve as an intermediate host. They ingest eggs from contaminated food, water, and soil. The eggs hatch in the gut lumen and release a 6-hooked oncosphere that penetrates the intestinal wall and migrates through the circulatory system into the liver. The oncosphere develops into multi-chambered, thin-walled, hydrated cyst that proliferates by successive outward budding of the germinal liver to form numerous vesicles embedded in immune reaction of the human host, namely granulomas, fibrosis, and necrosis. Protoscolysis develop within these vesicles. The definitive host becomes infected by ingesting the metacystode containing organs of the infected intermediate host. After ingestion, the protoscolosis evaginate, attach to the intestinal mucosa and develop into adult worms in 32 to 80 days. Man is an accidental dead-end intermediate host and occurs infection by ingesting eggs from food, water, or soil, or by direct contact with the definitive host. The cyst vesicles in man are sterile and lack protoscolosis. Human alveolar echinococcosis presents as expanding infiltrative liver tumors with local and distant metastasis. The liver tumor may be detected incidentally on routine liver imaging or often presents as pain in the right upper quadrant. The tumor may show central necrosis and resemble a liver abscess. Involvement of the centrally placed bile ducts causes biliary obstruction, episodes of cholangitis, liver abscess, sepsis, and multi-organ failure. Invasion of the portal venous system and hepatic outflow tract leads to portal hypertension and Budd-Chiari syndrome. Infiltration to adjacent organs, namely the heart, adrenals, diaphragm, mesentery, and pleura, causes specific organ dysfunction. Diffuse liver disease can cause liver failure. The tumors metastasize to lungs, present as lung nodules or infiltrative liver disease, to the brain as mass lesions, and to bones as tumors and fractures. Left untreated, the disease is fatal within few years. Diagnosis and evaluation of alveolar echinococcosis is complex and multidisciplinary. Given the slow growth of the lesion and non-specific clinical presentation, a high degree of clinical suspicion is needed. Multimodal imaging is the cornerstone for clinching the diagnosis. Ultrasound and CT scans are good for detecting liver tumors with calcification and tumor characteristics, extension, and invasion. MRI is more specific as it helps to evaluate disease activity on T2 weighted images, diffusion weighted characteristics on T1 weighted images, and biliary tract on MRCP. PET scans are very specific as FDG uptake is markedly increased at the lesion's periphery, determining the metabolic activity and viability of echinococcus scolosis. Serology based on EMB2+ based ELISA is sensitive and specific and often confirms imaging results. Histological findings include strongly PS positive, microcyst, extensive necrosis, granulomatous inflammation, and calcification. DNA identification methods are now routinely used on biopsy or fine needle cytology specimens to diagnose alveolar echinococcosis in patients with unusual imaging aspects and negative serology typified by immunosuppressed patients. In 2003, Kudama et al. From Japan proposed classifying alveolar echinococcosis lesions from type 1 to type 4 through MRI identification of lesions, solid and cystic portions. The presence of microcysts appears to be strongly correlated with PET scan hypermetabolic activity around the liver lesions and suggests disease with activity. The absence of microcysts with solid and large cystic tumors are often caused by old inactive lesions. Because the growth pattern of alveolar echinococcus resembles liver cancer, WHO, guided by TNM classification and staging, has proposed PNM classification to stage the disease and plan treatment. P represents parasitic mass in the liver, is divided into PX to P4, N describes the involvement of the neighboring organs, and M represents the occurrence of distant metastasis. Based on the PNM classification, the disease is divided into 4 stages. Early localized disease under stage 1 and 2 are amenable to curative liver resections. A 2-year chemotherapy is to be given, and serology with ultrasound is done every 6 to 24 months, and MRI or PET and CT every 2 to 4 years to watch for disease recurrence. The disease is considered healed after 10 years without recurrence. Managing advanced local or distinct disease under stage 3A, 3B, and 4 is a complex clinical problem. Generally, radical surgery is done in select cases. Palliative surgery is discouraged. Long-term chemotherapy is the sole form of therapy and may arrest the progression of disease. Patients with biliary and vascular complications often need interventional or surgical procedures. Liver transplantation and ex vivo liver resection transplantation are done with localized advanced disease. What about status of alveolar echinococcus in India? I reported the occurrence of alveolar echinococcosis for the first time in India in 1980. The patient was a 40-year-old male from Udi who presented with a large liver mass of 18 to 14 centimeters with extensive necrosis and cavitation. The tumor had invaded inferior vena cava, blocking its ostium, causing Budd-Chiari syndrome. Hepatic lesion had infiltrated into the right atrial wall, resembling an atrial tumor. The tumor involved the diaphragm and left pleura as well. Patient died after surgery and had a diagnosis at autopsy. Only a few isolated cases were reported after this report, and alveolar echinococcus was never a matter of concern in India. However, from 2012 onwards, there have been several case reports and series from North India, including Kashmir. Taking the lead from these reports, we planned several studies on alveolar echinococcus in Kashmir, India. A prospective study was done to find the number of cases of alveolar echinococcus from a cohort of 110 cases of echinococcus seen at Dr. Kuru's medical clinic from March 2019 to April 2024. Next, a systematic review was done to document cases of alveolar echinococcus from Kashmir from 1980 to April 2024. We performed epidemiological studies to find the prevalence, incidence, and the disease burden of alveolar echinococcus in Kashmir. We debated whether the emergence of the disease in Kashmir is a myth or a reality and chalked out future directions to face the challenge. The diagnosis of alveolar echinococcus at Dr. Kuru's medical clinic was made based on clinical, serological, imaging, and histological findings. Echinococcus hydrated serology (IgG) was performed by ELISA using Echinococcus granulosus hydrated fluid. This is the first-line test for immunodiagnosis of both cystic as well as alveolar echinococcosis, with a diagnostic accuracy of 95% for alveolar echinococcosis. Imaging goals included characterize the liver mass, define the extension of the tumor mass towards the liver hilum involving vascular system and biliary tract, extension towards liver capsule infiltrating the surrounding organs, parasitic viability and activity at the onset and on follow-up, tumor volume and future residual liver volume, distant metastasis. For this, we employed ultrasound, CT, MRI, and PET scans with their selective advantages. With all that, confirmation of diagnosis needed histological proof of alveolar echinococcosis. A prospective study of 110 echinococcus cases at Dr. Kuru's medical clinic from March 2019 to April 2024 showed 98 cystic and 12 cases of alveolar disease. Could the recent surge of alveolar echinococcus in Kashmir be due to increased awareness, better healthcare facilities, and improved diagnosis? Based on our experience for years, it seems unlikely. We have prospectively followed 229 echinococcus cases from 1989 to 2005 at SKIMS, Srinagar, and 301 cases from 2005 to 2019 at Dr. Kuru's medical clinic. All cases had cystic echinococcus and no case had alveolar echinococcosis. Thus, the emergence of the disease is of recent origin and unlikely related to increased awareness of the disease or improved diagnosis. Of the 12 cases of alveolar echinococcus, there were 4 males, 8 females. The age of patients at presentation was 46 years. All patients were residents of Kashmir Valley. Patients belonged to tribal population and lived either within the low mountainous region of Kashmir or border areas of the valley adjacent to the mountainous ranges. The livelihood of these tribal populations was closely related to forests, and they would often visit forests over the years. 2 patients were detected during routine ultrasound examination for unrelated causes, while remaining 10 were symptomatic. Patients complained of pain in the right upper quadrant, icterus, generalized itching, and pains with arthralgia and severe fatigue. The mean duration of illness was over 2 years. Physical examination, 7 patients revealed firm to hard liver with rounded margins and irregular surface. 1 patient present with features of liver abscess due to massive tumor necrosis. Physical examination was unremarkable in remaining 4 patients. Hydrated serology was strongly reactive in all cases. Liver imaging was remarkable as 15 liver tumors were seen. 9 patients had a single tumor, while 3 patients had 2 tumors, each in either lobe and different liver segments. 11 tumors were placed in the right lobe, while 4 tumors were seen in the left lobe. Tumors were large, bulky, and ranged from 5 centimeters to 15 centimeters, with an average of around 9 centimeters. Tumor volumes determined by contouring through HORA software were on an average size of 426 cubic centimeters. Tumor characteristics were evaluated using various imaging methods, including grayscale ultrasound with Doppler, CT scans, and MRIs. 6 patients all had PET scans. Of interest, MRI T2 weighted images classified tumor masses as Kodama 1 to 3 in 10 and Kodama 4 to 5 in 5 lesions. PET scans in all 6 patients showed active disease by revealing a central hypometabolic component and a rim of intense FDG avidity in the periphery resembling a donut. The tumor had a strong invasive nature as seen on imaging. 3 peripheral masses had encased peripheral vascular and biliary elements. However, 8 tumors had spread centrally to encase and invade vascular and biliary structures in the hilum. In addition, 9 tumors had spread peripherally to involve liver capsule, ligaments, diaphragm, and omentum. Right adrenal masses were detected in 4 patients. Lung metastases were seen in 2 patients and showed up as lung nodules and hilar lymphadenopathy. A PNM scoring placed the disease as stage 3 in 3 patients, stage 3B in 4 patients, and advanced stage 4 in 5 patients. Histology of the tumor material available on needle, laparoscopic, or resected material showed necrotic lesions with granulomatous inflammation and calcification. However, the hallmark was presence of slender, thin-walled vesicles with bizarre configuration that stained strongly with PS. These vesicles lacked the presence of protoscolices, indicating these were sterile. 3 out of the 12 patients had surgically curable disease. 2 patients had successful procedures, and a 3rd patient refused surgery and was lost to follow-up. 1 patient with infected necrotic abscess had tumor aspiration followed by surgical excision of the cyst contents. 8 patients with advanced disease were on chemotherapy with albendazole along with pranzacutal. We have been impressed by chemotherapy as patients had relief of symptoms and tumor masses had regressed as evaluated clinically and on repeat ultrasound examination. Of significance, none of these patients had disease progression. However, repeat MRI examination at 1 year in 1 patient and MRI and PET scan at 5 years in another patient continued to show radiological evidence of active disease. Next, we did a literature search to find out all cases of alveolar echinococcosis in India from 1980 onwards, when I described the first patient from India. For this, we used a systematic review under the PRISMA guidelines, which consist of 27-item checklist and a 4-phase flow diagram, including identification, screening, eligibility, and inclusion. Diagnosis of alveolar echinococcosis was based on clinical, serological, imaging, and histological findings. 3 search methods were employed, including published case of alveolar echinococcosis, cases from Dr. Khuru's medical clinic, and cases retrieved from other medical centers in Kashmir and North India. Based on this, we found 146 patients of alveolar echinococcus in India from 1980 to April 2024. Of these, 20 patients belong to foreign countries who visited centers in North India for surgical procedures, including liver transplantations. Of the 126 Indian nationals, 118, that is 93.6%, were permanent residents of Kashmir. Of the 8 patients from other parts of India, 3 were Indian soldiers, 1 was a resident of Siliguri, West Bengal, and other 4 were from different parts, namely UP, Rajasthan, and Mumbai. Impressed by the magnitude of alveolar echinococcus in Kashmir, we envisaged further defining the prevalence, incidence, and burden of disease of alveolar echinococcosis, namely Delhi in Kashmir. Crucial for this all was determining the population in which the infection existed in Kashmir. We had contact details of 39 patients from Kashmir, including 12 cases from our clinic and 27 cases retrieved from other centers. On scrutiny, these patients resided in 22 villages with a total population of 79,196 from 5 peripheral districts of Valley. Of significance, none of the patients at the time of scrutiny belonged to Kashmir Valley bottom, and there was no case from other parts of Jammu and Kashmir, namely Kargil, Ladakh, and Jammu. Based on these data, we believed there were around 10 incident cases of alveolar echinococcus per year in Kashmir, with a prevalence of 146 per lakh and an incidence of 12.4 per lakh per year. Next, we use this model with standard assumptions to calculate the burden of disease of alveolar echinococcus in Kashmir. The assumptions included applying disability score of 0.3 for alveolar echinococcus as applied to hepatocellular cancer. Alveolar echinococcus is uniformly fatal in 8 years if left untreated, and life expectancy at 2050 for Indian population. The total number of dialyses for alveolar echinococcus in Kashmir, India was 33,100. Here I must mention that one daily means the loss of 1 year of healthy life. How do these data compare with published data from alveolar echinococcus globally? The disease is highly endemic in China, amounting to 95% of the world infection load. Other regions with high endemicity include Turkey and Central Asian republics, namely Kazakhstan, Kyrgyzstan, etc. I believe the endemicity of the disease in Kashmir is akin to these regions in Central Asia as of today. Next, I propose critically evaluating this evolving, emerging, and exploring important health problem in Kashmir. Kashmir is and will remain an ideal location for existence of the disease due to its geographical and ecological features. Altitudes, parks, sanctuaries, forests, and climate are suitable for maintaining the sylvatic cycle in wild animals, namely Kashmir red fox. Human exposure occurs in people who live or visit high altitudes, work or visit parks and wildlife sanctuaries, and eat wild fruit, chew grass, or are involved in haymaking. Dogs, as a definitive host in an urban cycle of alveolar multilocularis, can potentially cause community spread of infection in future. The emergence of alveolar echinococcosis in Kashmir needs a plausible explanation. Over the decades, in 1980, several phenomena have culminated in emergence of the disease in Kashmir. The most significant are massive deforestation and urbanization and contraction of the habitat of the definitive host. Kashmir red fox is highly accommodative to human dwellings, and the fox has shifted from altitudes to gardens and localities in peripheral regions for food. While so, we build orchards in the foothills of Himalayas in Shupian and Gandarbal to invite the host. Another important factor may be social unrest leading to more frequent movement to forests and climate change causing latitude and altitude shifts of small mammals, namely rodents. Several important steps need to be taken to address this evolving human threat to Kashmir and adjacent regions. Continued surveillance, determining the potential risk factors for spreading, and addressing their control. Of course, molecular studies are necessary to trace the origin of infection and develop clinical units to manage this complex disease. Finally, I leave you with these two cartoons to give a warning. Alveolar Echinococcosis infection at present in Kashmir is passing through sylvatic cycle. The definitive host is a wild animal, namely Kashmir red fox, and human exposure is limited to peripheral mountainous regions. The real danger is the change to an urban cycle where the dog becomes the definitive host. If it does happen, there will be a community spread and we'll start seeing cases from Kashmir Basin and other regions as well. Ladies and gentlemen, I thank you for your patience while listening. I leave you with this graphic abstract of what I said and believe. God bless.